This presentation will address the new process for screening and assessing those at risk for suicide. New requirements by the Joint Commission effective July 1st, 2019 are designed to improve the quality and safety of those at risk for suicide. Suicide screening for all patients, not just those that report suicidal ideation or depression, will help identify and prevent suicide. Patients being treated primarily for medical condition often have comorbid behavioral conditions and may be at risk for suicide. The Joint Commission requirement mandates that the organization must develop a plan to mitigate suicide based on the individual's overall level of risk and follow written policies and procedures to care for these vulnerable individuals. This slide shows the Joint Commission recommendation for the use of the Columbia Suicide Severity Rating Scale. This tool is recommended by numerous organizations, as you can see, and is validated and is evidence-based. The tool can be used in all settings, on all ages, and special populations, and it's free. Suicide is a major public health crisis in the United States. Let's take a look at a few alarming statistics. Every 15 minutes, someone dies by suicide in the United States. Suicide is the second leading cause of death for children 10 through 16 years of age, and bullying victims are 9 times more likely to consider suicide. It is the third leading cause of death among adolescents, and 10% of high school students attempt suicide each year. For adults, suicide is the fourth leading cause of death. More people die by suicide than motor vehicle crashes. Isn't that alarming? 45% of people that die by suicide have been seen by their doctors within 30 days prior to their death. This is why screening everyone is so crucial. Primary care providers have excellent opportunity for preventing suicide if they screen for suicidal ideation on all patients as part of their overall clinical evaluation. Here are just a few statistics for the state of Wyoming. On average, one person dies by suicide every 2 days. Suicide rates in Wyoming are consistently higher than the United States rates. Wyoming is currently ranked the third highest state for suicide mortality at 17.3%, just behind Montana at 21.7% and Alaska 19.9%. How can you help, you ask? You can help simply by asking a few questions about suicidal ideation and relevant behaviors, from a wish to die to an active thought of killing oneself with a plan and intent. If the answers to these questions are no, then the screening process is complete. The questions are standardized to help guide the interviewer to improve identification of those at risk for suicide. The Columbia Suicide Severity Risk Scale tool is simple and can be used with no mental health training required. It is effective in identifying those at risk. The tool is efficient because it will provide guidance on what your next steps will be to keep your patients safe. It is free and supported by evidence. This is what the tool will look like. You are required to ask every patient question number 1 and question number 2. And if the answers are yes to either of these 2 questions, then proceed to questions 3, 4, and 5. Question number 1. Have you ever wished you were dead or wished you could go to sleep and not wake up? And number 2. Have you actually had any thoughts of killing yourself? This is the screener. Again, if they answer yes to these 2 questions, then you must proceed to question number 3. Have you been thinking about how you might do this? This addresses their thoughts and methodology. Question number 4. Have you had these thoughts and had some intention of acting on them? This addresses their intent. And number 5. Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? Then ask about suicidal behaviors. Have you ever done anything, started to do anything, or prepared to do anything to end your life? Suicide ideation and behavior must be asked separately. Just because ideation is denied, it does not mean that there will not be suicidal behavior. You need to ask about suicide attempts regardless of lack of ideation. Ask about current and past psychiatric diagnoses. How is your patient presenting? Do they have any symptoms of anhedonia, which is a state of mind in which they find no pleasure in anything? What is their family history? What events triggered these feelings, and was there any changes to their treatment? And lastly, don't forget to ask about access to lethal means, especially with 64% of suicides in Wyoming occurring with a firearm. Step 2 is identifying protective factors. Does your patient state that they have a reason to live? Are they religious? Do they have a family that cares about them? Do they have children that need them? These are all protective factors that can make it less likely that they will consider suicide. Part of the suicide assessment required by the Joint Commission is to stratify a risk level. The assessment directly asks about frequency. How many times have you had these thoughts? Duration. When you have thoughts, how long do they last? Controllability. Could or can you stop thinking about killing yourself or wanting to die if you want to? Deterrence. Are there things, anyone, or anything that stopped you from wanting to die or acting on thoughts of suicide? And reasons for ideation. What sort of reasons did you have for thinking about wanting to die or killing yourself? Was it to stop the pain or make someone angry? Stopping the pain is a much worse answer. When completing step 3, please refer to step 1. These are specific questions about their thoughts, plans, and suicidal intent. This gives you a 2 to 25 score that will help inform clinical judgment about risk. For intensity of ideation, risk is greater when thoughts are more frequent, thoughts are of longer duration, thoughts are less controllable, fewer deterrents to acting on thoughts, stopping the pain is the reason. And remember, no one else can play your part. Step 4, determining level of risk and interventions. Nothing will change to your current process after the screening and assessment is completed. The highest suicide risk patient will be placed in the safest environment. You will notify the attending physician, call Southwest Counseling, and attend to the needs of the patient. Moderate suicide risk is the same as high risk. Notify the physician and call Southwest Counseling for an evaluation. Low-risk interventions will be dependent on physician preference. All patients will be given a handout upon discharge with available resources for mental health counseling and the suicide prevention hotline number. This assessment is to be completed following the patient interview. This part is easy. Just check the boxes of what you observed or what the patient or family told you. Step 5, documentation. The nurse must document the individual's overall level of risk for suicide and the plan to mitigate the risk for suicide in the electronic health record. Your clinical observation of the patient, relevant mental status, and a brief evaluation summary about what is observed and what the patient said during the interview. Were there any warning signs, risk indicators, protective factors, access to lethal means? Was the information provided from the patient or others? What assessment data was obtained that supports your risk determination and the rationale for actions that were taken? Was the patient provided resources, and was there a safety plan upon discharge? Here are some myths and facts about suicide. Myth number 1, you should never ask people if they're thinking about suicide because talking about it will give them the idea. That's completely wrong. Asking people does not give them the idea about suicide. It is important to talk about suicide because you will learn about their mindset and their intentions. Another myth, people who talk about suicide are trying to get attention. Fact, people who die by suicide usually talk about it first. They are in pain and are reaching out for help. Take it seriously, always. Here are a couple more myths about suicide. Once people decide to die by suicide, there is nothing you can do to stop them. Fact: suicide can be prevented. Most people who are suicidal do not want to die, they just want their pain to go away. And people who talk about suicide are trying to manipulate others. No, people who talk about it are in pain and need help. This is a list of some organizations that use the Columbia Suicide Severity Risk Scale. Please notice that the Joint Commission is at the top of the list. Again, anyone can use this tool and no additional training is needed. Properly assessing a person's risk for suicide helps everyone in the community determine next steps and saves lives. Thank you for listening and watching, and together we can make a difference in preventing suicides.